title, this is a little bit of a debate, if you like, friendly debate. And the title, at least my title, is MPS SPECT is and will remain the workhorse for ischemia testing. I've got no conflicts to declare, apart from the fact that I work in both SPECT and PET. In deference to the next speaker, Dr. Panithaya, who is, as you will know, president of the American Society of Nuclear Cardiology, I thought I would start with a quote from a past president of ASNC, friend and colleague Jim Udelson. MPS PET is not yet an essential component of every modern-day clinical nuclear cardiology. Of course, the operative word is yet, and it's 2016, so what has happened, if anything, since then, to modify that statement from ASNC? Before I launch into discussion of SPECT and PET, let me just say I don't actually think that this is the most important problem that faces us. If you're sitting in a chronic coronary syndrome multidisciplinary meeting, there's many questions that arise. Aren't history, examination, ECG, and angiography all that are necessary? Why do we need you? If we do need something else, anatomical or functional? If functional, how do you choose between the various options that are there? And of course, if you are going to choose scintigraphy, then SPECT or PET. So to be honest, I think these are the more important questions to justify the role of functional imaging by radionuclides in a clinical setting. But we're going to be talking about SPECT or PET. But just remember to defend the functional imaging rather than whichever way that you do it. So let's talk about PET and SPECT. So the IAEA will tell us how many gamma cameras and PET scanners there are around in the world. This is a very big survey, but basically there's almost 5 times as many SPECT cameras around the world as there are PET. If we go to Europe, this is in October 2023. These are dots for wherever there is a PET scanner, and the solid dots mean there's more than one in that site. You'll see that England is relatively well populated, maybe the same as France, perhaps not as much as Germany. But if you go to the other UK countries, Wales, Northern Ireland, Scotland, you'll see you're much less well off. Indeed, if you're in the Shetland Isles, you're probably better off going to Norway than you are to Scotland. And among that, of course, all of these are mainly doing FDG oncology PET, and within the UK there are only 4 centres that are doing rubidium PET at the moment, 3 of which are in London and 1 of which is in Manchester. So if you come from anywhere else, you don't have a lot of choice. Let's go to the USA, which is a different place from the UK, of course. But these are some interesting numbers from the Medicare population up to 2022, and you can see that SPECT is very slowly declining, and some of the other tests, including PET, are increasing. But notice that this is a logarithmic scale. So even more recently, there's something like 10 times the number of SPECT scans done than PET scans in the USA, at least in the Medicare population. If we come to Europe, this is slightly older numbers from the Eureka registry, but it is 24 countries, 73 centres, 5,000 patients. And you can see that actually SPECT is the commonest functional coronary imaging technique. Stress echo less, MRI, certainly perfusion CT. PET doesn't even register. These are slightly old numbers and it will register more, but it's not going to be challenging SPECT in Europe. If we come to the UK, sadly there are no detailed numbers, so PET doesn't feature at all here, but you can see that MPS, Myocardial Perfusion Scintigraphy, is more or less static up to 2016-17, so these are old numbers, and particularly CT imaging is increasing, especially after the NICE guidance that promoted it, quite rightly, at least in low likelihood cases. So there's no PET that we know of here. Shama, forgive me, please, but these are numbers from numbers of studies done by SPECT and by PET at the Royal Brompton and Harefield hospitals, and there's obviously discontinuity with COVID, but you can see that even in a centre that has access to rubidium PET, that SPECT is more commonly performed. So let us go back to the USA, because the USA-UK comparisons are interesting, but they're different places, and in one respect, these are the studies reported, the percentage of studies reported by cardiologists in the different modalities over the years. And you can see that SPECT, stress echo, PET, and MRI are on the whole in the hands of cardiologists. CT is on the whole in the hands of radiologists. So is there an element of self-referral here when it comes to the choice of tests to do? Well, there may be. Here is a quote from Professor Reeves saying, "It should be noted that there is a strong financial incentive," bear in mind this is Medicare and USA, "to convert MPI studies to PET, which are reimbursed at a higher rate." Now, let us look therefore at some reimbursement numbers. I've translated Medicare reimbursement to current pounds, and you can see that for CTCA, stress echo, and perfusion MRI, they're roughly similar ballparks, whereas the reimbursement, at least in the USA, for SPECT and for PET, is considerably higher than it is in the UK, something like twice as much reimbursement for SPECT in the USA compared with the UK, and 2.5 times for PET. So is there an element of self-referral going on here? And certainly the profit margins in the USA for PET must be much larger than they are for SPECT. So let's look in more detail at comparisons between the techniques, imaging characteristics first of all. I don't really like these sort of slides, or this slide, because I think it's pseudoscience. I'm not sure that these are very well documented in the literature, but you can see that in terms of the uptake curves, well, water is never going to feature as a routine, a great tracer, but not as a routine across the board, is it? Ammonia is equally difficult. Flurpiridaz, we sadly don't yet have it. I hope we will have it. It would be great, and it would change things if we do have it. Look at thallium. It's right up there, better than rubidium, and certainly better than the technetium tracers. And don't believe what they say about the radiation exposure for thallium. It's actually lower by some of the modern ICRP estimates than are commonly quoted. So let me show you a very interesting patient to illustrate these concepts. He's a 76-year-old man, always asymptomatic, but he had a 3-vessel PCI back in 2013. He's known to have untreated diagonal disease. He's on medical therapy throughout, so presumably his disease is stable and not changing. It happens that he had a thallium scan, a tetraphosphamine scan, and a rubidium scan over the years, and you can see the defect, the stress defect from the diagonal disease quite well with thallium. With tetraphosphamine, okay, it's there, but much less obvious. It's also there with rubidium, but certainly not as good as with thallium. So these 3 scans illustrate very nicely that the hierarchy of tracers. Where we would be with flurpiridaz, we do not yet know, but we hope we will have it. In the interests of time, no, I'm going to skip over this one to do with resolution in the interests of time. So let's look at diagnostic performance. This is a meta-analysis from ESC guidelines going back a little bit, but from the studies quoted, giving very similar values for sensitivity and specificity for vasodilator SPECT and for PET. So in good hands, the accuracy of the techniques should be similar. I hope this is in good hands because we were responsible for the core lab from the Vinci study, a European study, and I'm admittedly selecting only the patients who had good quality images here, and you can see that we read these more for specificity than for sensitivity, but you can see that actually the accuracy of SPECT and PET was very similar. Also, the core lab for the Pacific study, again, reading much more with SPECT for specificity than for sensitivity. Overall accuracy was identical to PET in the good quality images. And I'm going to say this, so we'll talk a little bit about quantification, which will crop up, I'm quite sure, in the next few talks. Here's an ASNIC case of the month, illustrating the value of quantification using rubidium PET. It's a 69-year-old man with typical angina with regadenoson. He had chest pain, he had a fall in blood pressure, he had a raise in ST segments, he had a fall in ejection fraction, he had something called transient RV prominence. Can you see that the RV is more prominent here? Stress than rest. So this is meant to illustrate that from the qualitative images here, the circumflex territory looks okay, doesn't it? But actually, in terms of the numbers, it's not okay. But I have to tell you that if you didn't know that already from the qualitative images, then you've missed a trick with SPECT, because the transient RV prominence was telling you that no area was normal in those SPECT images. So yes, it's nice to have quantification, but there are ways around it if you are doing qualitative SPECT. Looking more scientifically, perhaps, at the receiver operating characteristic curves, here against FFR less than 0.8 for, the colors in in green are the sum stress source, so the qualitative images, and in red, the myocardial quantification. So there's actually no difference in the accuracy there between qualitative and quantitative reads. And you can see that if you add in, so this is the qualitative read, if you like, sensitivity and specificity. If you add in the quantitative numbers, then you're gaining perhaps in sensitivity, but losing in specificity. So quantification is good. And let me just give you my take on this quantification. This is unpublished from moi. If you have quantification, 50% of patients, I would say, well, thanks very much, but I knew that already. Quarter of them I would say, oh, thank you, I like that. And a quarter of them I would say, I'm not sure that I really believe or understand you. Something must have gone wrong there. So it's not necessarily the be-all and end-all. Let's talk about prognosis and management. Well, I can skip over this because everybody can do this, can't they? You know that with some stress scores and with ischemic burdens, you can rank patients according to their likelihood of future coronary events. And there's lots of admittedly retrospective studies now looking at this, initially from Cedars-Sinai, but this is more recently using solid-state cameras, looking at the hazard ratio for cardiac death, infarction, or early revascularization of surgery or intervention versus optical medical therapy against ischemic burden, with a crossover somewhere between 10 and 15% ischemic burden. So yes, SPECT can tell you which patients are going to benefit from intervention, but then so can PET. And here's an almost identical study looking at the same with PET. So here's the final little topic of cost effectiveness. Well, what cost effectiveness information is there? This is not strictly a cost effectiveness study, but we're back to Medicare, and I like to show it because it's over 250,000 patients who might have had SPECT or MPS first, usually SPECT, or CT first. So this is functional versus anatomical imaging, and you can see that if you go first to anatomical imaging, then you are twice as likely to have coronary angiography. You are 2.5 times as likely to have PCI. You are 3 times as likely to have CABG. But are you more likely to be alive? Well, you're slightly less likely to have had an infarct, but you're no less likely to be alive. And this is at a cost. It's cheaper if you do the functional test first. So it's not strictly a cost effectiveness study, it's a cost minimization study, but it is in the realm of SPECT, and there's now solid data supporting functional imaging by SPECT for management. Again, in the interest of time, I'll pass over our own Empire study and show you this. Again, it's not to do with PET, it is to do with SPECT, but it is the only randomized, prospective, cost-effective study in the area. I won't tell you the details, but it's 900 patients with stable chest pain, abnormal stress ECG, randomized to going straight to angiography, SPECT, perfusion MRI, or stress echo. And this is looking at the likelihood of being cost-effective compared with invasive angiography first, according to willingness to pay. And in the UK, NICE would say that we are willing to pay between £20,000 and £30,000 per quality-adjusted life year. And you can see that MPS SPECT is likely to be cost-effective with stress echo and perfusion CMR much less likely, or rather unlikely. So are there any comparisons between SPECT and PET for cost effectiveness? Well, we can go to the SPARK study. This admittedly is a modeling study rather than a prospective clinical study. And this is a complex slide, and I've got a few minutes left, looking at the increase in life years added and the increase in the cost of SPECT versus PET. And most of the data here are in the more expensive and less effective for PET compared with SPECT. So the suggestion is that PET is not cost-effective compared with PET. Slightly better here in terms of science of the study. This is randomizing patients referred for perfusion imaging to SPECT or to PET. And looking at the primary outcome measure here was whether diagnosis was successful, and it was equally successful with both. There was no difference between the anti-anginal use, between referral to catheterization, and between revascularization. There were some differences here in that with high-risk studies, SPECT was with PET was more likely to lead to catheterization and to revascularization. But was there any difference in the quality of life for the patients? No. So not favorable for PET, I'm afraid, in terms of cost effectiveness. So look, let's try and bring this together. Is and will remain. Is a given, okay? Will remain. I don't know. It's predicting the future. Niels Bohr said prediction is very difficult, especially if it's about the future. And Abraham Lincoln said the best way to predict the future is to create it. So please do not think that I am in any way against PET perfusion imaging. Indeed, if I had the option for myself, I would have it. But the debate is more along the lines, what will be the workhorse? And if we wish to create the future where PET is the workhorse, then it is up to us to make sure that we can provide high-quality PET that is effective and is cost-effective. Sadly, I don't think we are there yet, but I know that Dr. Panithaya will tell us differently. Thank you.